This is a lecture on PUL and ectopic pregnancy given in March 2021 by me, Dr. Caroline Prentice.
So some of the terms, we use a lot of abbreviations. I'm just going to go through those briefly. A lot of these will be familiar, but not all of them. So EPU referred to the early pregnancy unit, so a specialist place for people up to about 12 weeks of pregnancy to come and have scans and bloods and things that we do. And intrauterine pregnancy just refers to a pregnancy correctly located within the endometrial cavity. In this context of PUL and ectopic, it doesn't mean it's viable or a healthy pregnancy, it just means that it's in the right place. PUL is a pregnancy of unknown location, so that is where you have a positive pregnancy test, either on urine or serum bloods, and you cannot see that pregnancy on scan. So it's a diagnosis that can only be reached after a transvaginal ultrasound scan. An ectopic pregnancy, or EP, is a pregnancy anywhere outside of the endometrial cavity. Beta HCG is beta human chorionic gonadotropin, and that's the hormone that we test for. It's in the urine pregnancy tests and in the bloods that we do. Progesterone is another hormone that we'll talk about today. So it's secreted by the ovary, by the corpus luteum in pregnancy, and then by the adrenal glands as well. And then UPT is the abbreviation for urine pregnancy test, so a urinary beta HCG test. So what I'm hoping to cover today is how we manage PUL, how we investigate, and then how we interpret the beta HCG and progesterone. We will talk about types of ectopic pregnancy, and then I've got a lot of ultrasound and then their corresponding surgical images, so that you've got a sort of a physical representation of the concepts that we're talking about. I'm going to cover management of persistent PUL and then conservative medical surgical treatment of ectopic in a different lecture. I think as I was going through, I felt it was just too much to cram into one session, and I want to give hopefully a little bit of time at the end for us to discuss. So I will be leaving that to next time. So the first part we're going to talk about is pregnancy of unknown location. So this is a working diagnosis for approximately 10% of patients presenting to the early pregnancy unit. The better the scan machines we have and the better sonography skills that our team have, you're going to lower the incidence of PUL. The reason for that is if you've got a better spec machine, you're going to pick up smaller ectopics, you're going to get better images, you're going to see and visualize the pregnancy better. If you've got people that are more skilled, they'll be generally will pick up more small ectopics and things like that. So that's why your skill mix matters. This is all exclusively talking about transvaginal scans. So the pregnancy has to be quite big for you to be able to see it via a transabdominal scan. So for a true working diagnosis of pregnancy of unknown location, we're talking about transvaginal scans in the main part, and that can be a bit difficult if people are declining those. So with a pregnancy of unknown location, it's a working diagnosis. I keep referring to it as a working diagnosis because actually the final diagnosis is either going to be an early intrauterine pregnancy. So the pregnancy is in the right place, but it's just too small for us to see with our scanning. And sometimes if people have things like a very fibroid uterus, if they've got very raised BMI, that can be particularly difficult to see. Ectopic pregnancy not seen on a transvaginal scan is the other reason. So actually it's an ectopic pregnancy, it's in the tubes, it's somewhere else, but for whatever reason we're not able to see it. And again, it could be that it's very small, it could be that it's in a very unusual location, or raised BMI, bowel activity, all these things that make scans more difficult. And then the third reason is that they may have already miscarried. So it may be that they were pregnant, it was an intrauterine pregnancy, they've passed all of the pregnancy tissue, so the womb looks empty, and we've just scanned them after that process when they've still got a positive beta HCG. So with our investigations, we're trying to identify which group does the woman belong to, which of these categories does she fit into. We want to minimise harm, we don't want to miss anyone with an ectopic pregnancy, and we don't want to tell someone they've had a miscarriage when they haven't, but we also need to try and limit unnecessary visits or diagnostic surgeries. So it's balancing your harms and your investigations and interventions. So how do we assess someone in this situation? So typically they will have already presented to the early pregnancy unit for some reason. They will have had a scan, which has then led to a working diagnosis of PUL. So we should be asking them, do you have any pain? You know, could this be an ectopic pregnancy? Have they got cramps associated with miscarriage? Do you have bleeding? How much bleeding? Are you passing clots? Have you passed any tissue? What's happened in the past? Have they got, you know, a history of recurrent miscarriage? Have they had previous ectopic pregnancies? Observations, do they look well? Are they stable? Are we missing someone with an unstable ectopic? Are they bleeding inside? On examination, we're looking for tenderness. We might want to do a speculum if they're bleeding very heavily. If their os is open, it would indicate that this is, you know, miscarriage, that they've passed a pregnancy sac or pregnancy tissues recently. Is there cervical excitation? So when you examine them and you touch the cervix, are they very, very tender? Does it cause irritation? And that's a sign of internal bleeding that we would need to worry about. And we're going to do some bloods. So we're going to do a beta HCG, a progesterone. We might also, if we're worried and we're thinking this is more likely to be an ectopic, we also think about adding in a full blood count to see what's their starting level of haemoglobin, and a group and save in case they end up either going to theatre or needing a blood transfusion. So the management, if someone is unstable, so if they have, you know, tachycardia, low blood pressure, if they're in a lot of pain, we're not going to necessarily wait. We're just going to treat them as an ectopic, and you would do a diagnostic laparoscopy. So popping a camera in through the tummy button, having a look, is there an ectopic pregnancy? Are they bleeding? So when we're talking about interpreting beta HCGs and all these things later on, remember that actually they have to have passed that first test, and that is that they're well enough to be looked after at home. So if anyone with significant pain or unstable, we're not going to manage them as a PUL, we're going to manage them as a suspected ectopic. And that's quite an important concept to sort of remove that layer of people. So if they only have very mild symptoms or indeed no symptoms at all, these are the people that we're going to manage as outpatients. We're going to do their initial bloods, send them away with a telephone number, and ask them to come back in 48 hours to do another beta HCG. It's important that we give them some written information. So it's quite a difficult concept for patients that might not be expecting this. So some written information about what it means to have a PUL, some signposting if they wanted to read, you know, if it sounds very much like a miscarriage, you might already want, you know, they might want some information. You can point them in the direction of the Miscarriage Association or Tommy's. I would give them a telephone number, so if anything changes, if they develop, you know, severe pain, shoulder tip pain, feeling dizzy, feeling unwell, or indeed heavier bleeding, then they need to have a number to call for advice and somewhere for them to return. And it may be that you just need to tell them to go to ED or A&E if they have those symptoms. So it's important to think about how patients feel at this situation. So we deal with it a lot. As we've said, it's about 10% of our workload in EPU. But patients are more likely to feel confused. They probably came expecting to be told either that this is a miscarriage or not a miscarriage. And it's not a black and white outcome. We're saying it could be one of many things, and we don't know. We don't know what it is. We're going to ask you to come back. And that can feel quite frustrating to have to come back for more tests and more visits. It can lead to women thinking that we don't know what we're doing, and it's important to explain the concept carefully so that they have trust in our service. They may feel impatient, you know, why are we asking them to wait days? Why can't we just, you know, tell them what it is now? And in some cases, this can go on for weeks, this not knowing. And they may be worried. They might be scared once we've said, you know, this could be a pregnancy in your tube. That's quite a scary thing to hear, that you might have an ectopic pregnancy, and the risk associated with that. So it's worth just thinking about how you're going to communicate this situation with your patient. How are you going to explain it to them in a way that they understand? So before we go on to talk about how we interpret hormones, I just wanted to make sure we're all on the same page about what these hormones are, and why we're looking at them. So a beta HCG, as we've said, is a human chorionic gonadotropin. It's secreted from the trophoblast cells, and these are these very early cells from implantation, and they later go on to form the placenta. If you have a positive beta HCG, it confirms the presence or the recent presence of pregnancy tissue. And the reason I say recent presence is even with a miscarriage where you've passed everything or had surgical management, it takes time for all of the beta-HCG to be excreted in the urine. There are rare tumours that do secrete beta-HCG, things like molar pregnancies and a couple of unusual developmental tumours, but they are rare, and so I'm not covering those today. Progesterone is secreted from a few different places, so by the adrenal glands, which are the glands that sit above your kidneys, and then from the ovary itself. In early pregnancy, it comes from the corpus luteum, so that's where the egg has been released from the ovary, and then where that cyst was, that ovulation cyst, continues to release hormones to support the pregnancy. From about 10 weeks, if you've got a viable, healthy pregnancy, the progesterone is then secreted by the placenta, and that's one of the reasons why it's used as a supplement. So if you've had a woman that's undergone IVF, she hasn't ovulated because they've stimulated the ovaries in different ways, or it might be a frozen cycle or a donor egg. So they'll give a progesterone supplement to mimic the role of the corpus luteum whilst the placenta is growing big enough to be able to support itself. There are some trials that show it can be helpful in miscarriage, in recurrent miscarriage. The evidence isn't particularly strong, and it's not something that we tend to recommend. There is better evidence for it preventing either very late miscarriage or very early preterm birth. So some women will be on progesterone supplements for those specific reasons. If they are, then you can't use it as part of your investigations because you're going to get an inaccurate result because of the supplement. So in a viable intrauterine pregnancy, the hormone levels that you would expect, so you've got day 0 here is the first day of the menstrual period. You ovulate around day 14. It does vary from women to women, longer cycles, particularly with things like PCOS. So with ovulation, you then start to see this steady increase in the progesterone. If the egg that's been released is fertilized and implants, that then continues to rise, so you'll still get this rising progesterone. If implantation doesn't occur and the woman is not pregnant, then that will taper off back down and go to a much lower level, back to where you would see at the start of the menstrual cycle. So day 28, you can see from implantation, you'll then expect these trophoblastic cells, once they've implanted, to start dividing, and they will secrete increasing amounts of beta-HCG, which is this big peak that you see here. And after about week 12, that starts to fall down again and then taper off. It still remains higher than it does right at the start of pregnancy, but the highest levels of beta-HCG are seen around week 12. And that's why you might see some of these charts of how, the corresponding number of weeks to the amount of beta-HCG, but they're very variable and not to be relied on at all. So we test the beta-HCG and we test the progesterone, and then we look at the numbers of these and try to make a judgment about what's going on, which is what we'll come on to next. So we've taken back to our investigations. We've done our beta-HCG after us. We've had our transvaginal scan, showed a PUL, can't see a pregnancy. We've done our first hormone level. We've repeated it after approximately 48 hours. And what I would say is if you can't do it at 48 hours, I would do it later rather than earlier. If the levels fall by more than 50%, it's likely that this is a failing pregnancy. So say they've come for their scan, their progesterone was 2000, they come back 2 days later, the progesterone is 300. The beta-HCG is 300. That's more than a 50% fall, and it's likely to be a failing pregnancy. If the levels are rising by more than 63%, then we talk about this being a likely viable pregnancy. So you may have heard the concept of beta-HCG doubling, so doubling every 48 hours, and certainly that's a good sign of a viable pregnancy. But we would say the cutoff would be about 63%. So as long as they're increasing by more than 63%, we would say this is likely to be a viable pregnancy. If the levels are falling by less than 50%, so a suboptimal fall or a suboptimal rise, you're somewhere in the middle. So they're either sort of static or slightly falling or slightly rising, but not by less than 50% or less than 63. we would say this is quite suspicious, and we'd be more concerned about an ectopic pregnancy. The progesterone is sort of supplementary information is probably the best way to think of it. So the progesterone of less than 10 would suggest that this is unlikely to be a viable developing pregnancy, and it's unlikely to need intervention. The chances are that the pregnancy tissue will go away, will resolve on its own. More than 20 is more likely to predict a viable pregnancy, and if it's more than 60, that is strongly associated with a viable pregnancy. So you may see that these levels are reflected in some guidelines and not in others. The NICE guidelines don't recommend their use at all. The Royal College don't recommend their use at all. But if you look at lots of papers and the more sort of modern units and some of the newer risk models, they do tend to incorporate progesterone. So that's why we do it, because it's an extra level of interest rather than it being an absolute rule. So what are you going to do with these levels? So we're saying, right, there's been a fall of more than 50%. It's likely to be a failing pregnancy. So we would advise the woman, this is likely that you've had a miscarriage. We would discharge them, but ask them to do a urine pregnancy test just at home in 2 weeks and to call us if that's still positive, because we would need to look into why that would be. If the beta-HCG level has risen by more than 63%, it's likely to be a viable pregnancy. So we're going to want to scan them again, because actually if you've got an increasing beta-HCG, you've got dividing pregnancy tissue that's going to increase in mass, increase in size, and we would expect to be able to see it when we scan again, because the pregnancy is going to be larger and therefore easier to see. So you're going to arrange a repeat scan somewhere between 7 and 14 days. If they've got a higher beta-HCG, so if their initial beta-HCG was 1,500 and now it's 3,000, I would offer them an earlier scan, so you're more likely to see it. Whereas if they were in the low hundreds, say an increase of 100 to 300, then leaving it a little bit longer will give you a better chance of getting the diagnosis with your next scan and not bringing them back for a third scan. So if you're in this intermediate group, this group that we're worried about ectopic pregnancy in, these are the ones that can be a bit difficult to manage, and we do often bring them back quite a few times for various second opinions. If they were absolutely fine, completely well, no symptoms, there was no worries on their scan that we could see, and that we didn't consider them to be high risk, you could consider a third beta-HCG just to see, is it going to declare itself? Does it then suddenly rise or suddenly fall? Do you get more information from that third beta-HCG? You might want to rescan them. Sometimes getting a second opinion, you might be able to find someone, a more experienced sonographer, or even if they've, their bowels have settled, they don't have as much bowel activity, or they're not as uncomfortable, you may get more information from a second scan. So these are the ones to involve your senior decision makers with and say, look, I've got this woman, this is what's going on, what do you think we should do? And they can be tricky, these patients. There's no hard and fast rule. So all of this comes with an enormous warning. So not all of these pregnancy of unknown locations or ectopic pregnancies follow these rules. So you can follow the rules perfectly, as I've set out, or that was, a 50% fall, a 63% rise, whatever it is, you're always going to get caught out, always. And the reason is that these blood levels tell you about the activity of the trophoblastic tissue. So is that tissue dividing rapidly, dividing slowly, or is it not dividing at all, it's going away? What it doesn't tell you is the location. So you could have a pregnancy that is failing, the levels are falling, but actually it's failing in the tube, it's not failing in the womb. So about 10% of true ectopic pregnancies will have a beta-HCG pattern that looks like a failing PUL, and it's just that it's in the tube. You may also find that you've diagnosed somebody who's got these suboptimal rises in beta-HCG. They're sort of slowly rising, or they're static, and that could be an early ongoing intrauterine pregnancy. So you may want to, follow that patient up for a bit longer, consider a second scan. It may be that they've just got a sort of slower growing intrauterine pregnancy. The ones that really worry me, to be honest, is this last group. So the 15 to 20% of ectopic pregnancies that just behave like an intrauterine pregnancy. So they've got rising beta HCG, they might have doubling beta HCG. The reason they worry me is because it generally suggests a faster growing ectopic pregnancy. So even potentially a live ectopic pregnancy with a heartbeat, or one that's growing very quickly and is more likely to rupture. So these ones particularly worry me, where the beta HCG is rising, and that's why we always rescan them. And if it's higher, we rescan earlier so that we can see what's going on. And for this reason, it's really important that we consider the clinical picture as a whole. So what are the woman's symptoms? Does she have symptoms? Is she still telling you about this ongoing niggling shoulder neck pain that she has? That's worrying. Does she have signs? Is she tender during the scan? You sometimes see sonographers will put in their reports probe tenderness, and if they were uncomfortable. Have a think about the scans. Did they show free fluid? Was there evidence potentially of early bleeding inside their abdomen? And then also think about their bloods. What was the progesterone on that one? It was a rising beta HCG, but the progesterone was, somewhere in the middle, around sort of 40, something like that. That's quite worrying as well. The reason it's so difficult is because a rupture of an ectopic pregnancy is so unpredictable. So it can occur at any point. So you can have somebody who we're monitoring, their beta HCG is falling really nicely. They've got down to the low hundreds, and then they come in with a rupture. And I've seen it. It certainly happens. And you'll even get people that have a rupture with a negative beta HCG. So the pregnancy tissue was no longer dividing, it wasn't releasing more hormone, so their hormone level had dropped to 0, but actually there was still tissue there, and there might have been bleeding or a buildup of clots, and they've still ruptured. So it's so important to listen to the woman, to examine carefully, and to be prepared to be wrong when you follow these rules. They're not hard and fast rules. So the reason we tread so carefully, particularly, is because of ectopic pregnancy. It's common. 1% of all pregnancies will be ectopics, and it does have a mortality. Women do still die of ectopic pregnancy. It's usually the women that didn't know they were pregnant, and so it has a mortality of 0.2 per 1,000. When we talk about ectopic pregnancy as a concept, I think we generally think about tubal ectopic pregnancies. So that's a pregnancy that is in the fallopian tubes next to the womb. And the reason we think like that is because actually 90% of them are tubal ectopics, but there are other ectopic pregnancies that we need to be wary about. And these are often more difficult to diagnose. They're often more difficult to treat as well. So you can get a pregnancy that implants in a cesarean scar. An interstitial pregnancy is the portion of the tube where the tube meets the womb. A cornual pregnancy is in somebody that has a bicornuate uterus and they have a much smaller, underdeveloped rudimentary horn that then has a pregnancy in. You can get ovarian ectopics where the pregnancy is attached to the ovary. If somebody's had a previous surgery or a septum divided, they can get an ectopic pregnancy in the muscle layer of the womb. So rather than embedding within the endometrium, it embeds into the muscle in the womb. You can get pregnancies that embed into the cervix, and even abdominal, so completely free somewhere in the omentum or near the bowel. Some of the terms that we use around ectopic pregnancy, so a live ectopic is where you have a sac. Within that sac there is a fetus, and that fetus has a heartbeat. These are very high risk pregnancies. They're likely to be getting bigger quickly, and they're a higher chance of rupture. A heterotopic pregnancy is where you have an intrauterine pregnancy, so there's a pregnancy developing normally, or even a miscarriage within the womb, but also a pregnancy developing somewhere else, commonly in the tube. And then a ruptured pregnancy, the one that we're worried about, this is what kills women, and that's where the structure, whatever the structure it was containing the pregnancy, has burst open. And where you've lost that tissue integrity, there is then massive bleeding, and this can happen quite quickly, and they can lose quite a lot of blood. So this is why we do tread so carefully and do all these extra tests and things. So I quite like this diagram. I've taken this diagram from the Royal College, and it just shows you a little bit of anatomy and where you might find these ectopic pregnancies. So this is the tube here. You can see you've got the womb. The tubes have different portions. So we talk about the isthmic, which is the main sort of body of the tube, the ampulla, or sometimes we refer to it as the fimbria, these sort of finger-like projections, and that's the sort of more distal end of the tube. Interstitial is, you can see this is where the tube is joining into the womb, and this is a narrower part. You can see there's not enough room for it to stretch. These are a bit trickier to diagnose because they can sometimes look like they are in the correct place. These do get mixed up with corneal pregnancies, but a corneal pregnancy is specific to when there is a bicornuate abnormality or a rudimentary horn. So interstitial is the correct name for these pregnancies that are right in the where the tube meets the womb. Abdominal pregnancies could be anywhere. The cervical pregnancy is where they're much lower down, stuck in the cervix, but implanted, not to be mistaken with a sac that has been miscarried and is passing through. This is actually implanted within the cervix. So the risk factors, who's more likely to get an ectopic pregnancy? And these are things, the reason it's important to know about the risk factors is because this will be the sort of questions that you need to be asking people. So previous ectopic pregnancy, unfortunately, if you've had one ectopic pregnancy, we tend to say the risk of recurrence is between 10 and 17%. It depends a little bit on the cause really and where it was. If you've had a history of pelvic infection, so chlamydia, gonorrhea, tubo-ovarian abscess, PID, anything like that, you're about 7 times more likely to have an ectopic than if you didn't have that history. Infertility and assisted conception. So it's something actually that is slightly counterintuitive because you think with an IVF pregnancy, they've put it back into the womb on a, you've seen them scanning and they've put it in, but you are actually 3 times more likely to have an ectopic pregnancy if you have IVF. The history of infertility is probably representative that they may have some past undiagnosed pelvic infection. So that's where the infertility part comes in, or it may be that they have uterine abnormalities or have had uterine surgery. So if you become pregnant whilst there is a coil in situ, about 3 times more likely to have a ectopic pregnancy. And just smoking increases the risk by a factor of 2. Conception whilst using the progesterone-only pill specifically, or emergency contraception is also another risk factor, and having had any previous pelvic or tubal surgery. And pelvic and tubal surgery includes things like cesarean section, so it's always worth asking their pregnancy history. So I found this quite interesting, that when we think about the symptoms, we ask people, did you have pain? Have you got shoulder tip pain? Do you feel dizzy? Do you feel faint? Actually, half of women that have an ectopic pregnancy present with pain and bleeding. 28% will come only with bleeding, so no pain at all, but they have vaginal bleeding. And then just 14% come with only having pain. And then 8% will have other symptoms. So they might have diarrhea, and you can get that if you've got intra-abdominal bleeding. It's very irritant and it can cause diarrhea. They might get this shoulder tip pain. So that's when you get referred pain. Again, it's from hemoperitoneum, intra-abdominal bleeding that irritates the diaphragm and causes a referred pain up to the shoulder. And some people also describe it almost into their neck. And there are a group of women that will have absolutely no symptoms at all. And if you want to read the paper this is taken from, I've just included the reference down there. So how do we diagnose it? How are we finding these women with ectopic pregnancy? So it may be that we've picked them up from the PUL investigations that we've just been through. It may be that they've had a transvaginal ultrasound or even an abdominal ultrasound because they had symptoms. We see quite a few that referred from private scans. So, the private where people have gone just for a reassurance scan and have been found to have an ectopic pregnancy, or they've been through BPAS considering a termination of pregnancy and BPAS aren't sure if it's in the right place. We do get some that unfortunately just present acutely unwell, they've collapsed and they have a ruptured ectopic. Typically these are the women that we find down in A&E and take them straight to theatre. And you occasionally have them as incidental findings. So I've seen a couple, one picked up on an MRI scan that was done for a different reason and noticed to have this sort of chronic ectopic that wasn't causing any symptoms. and another patient that was taken for a routine gallbladder surgery, but when they put the camera in, they found all this blood and this bleeding tube, so she actually had a ruptured ectopic whilst she was there for an elective surgery. So it's always worth bearing in mind that not everyone will have the classic symptoms, and it should always be at the back of your mind, if somebody is pregnant, could this be an ectopic pregnancy? So I'm going to move on now. The next set of slides are for comparing ultrasound images and surgical images that we see. They can be tricky to see. I would suggest if you have if you're able to have a darkened lighting on a larger screen rather than a telephone or smartphone. These will, as I said, these will be online, so you can view them at your leisure later on. So don't worry too much if you can't see the detail. But they are ultrasound images are notoriously difficult to see, and that's why we scan almost in the dark. So you can see I've labelled here. We've got the uterus in a transverse view. We've got the left ovary, and then sitting in between the left ovary and the womb is this really obvious ectopic. So it's this little circular structure. You can see it's got a darker centre and then a bright white outside, and this is called a bagel sign. So it just looks like a bagel. And the reason it looks like that is it's an end-on view of the tube. So you're not looking at the tube lengthways, you're looking at a cross-section, and you've got a tube that you can't normally see on ultrasound, but it's dilated, it's full of pregnancy tissue, and that's why you can see it. So that's what we call a bagel ectopic. You can see this little black pocket in between the tube and in between, and that's fluid collecting around the outside of the ovary and around the ectopic. And that fluid, here it just looks completely black. So it's unlikely to be blood, but you've got to bear in mind any free fluid could be blood that you're seeing. So this is another similar image. So you've got the womb here, this time in a lengthways, longitudinal section. You've got the left ovary here, and again, next to the left ovary, this bagel sign. You can see here in the middle that it's fluid filled, and this is probably slightly more advanced in that you can see the actual gestation sac within it. So this is probably an early gestation sac with surrounding trophoblastic tissue within the tube. So this is a slightly more developed ectopic pregnancy. Here we've had an ectopic pregnancy that's developed even further. So we're outside the womb. You can see it's this, again, this circular structure that represents the tube. Within that is the gestation sac, and within that is the yolk sac. So this is a pregnancy that's developed even further to the point of having a gestation sac and a yolk sac. These are less common, but they are generally much easier to diagnose because they sort of shine out at you as you're scanning across, and you see the empty womb and then this pregnancy out to the side. This is a live ectopic. So this is this one's actually an abdominal scan. It was really large, this ectopic. So you can see here, zoomed in, this is the tube. Within the tube, you've got the gestation sac. This is the embryo. So you can actually even see the developing embryo. The colour on the image represents blood flow. So it's called Doppler analysis. So you put the Doppler on and it tells you if there is blood flow. The brighter the colour is the faster the flow, and the blue and the red represents whether the flow is coming towards or away from you. And you can see where the embryo is, there is a pulsation, and that's because there was a heartbeat. These are the big vessels that are in the mum, so just where the ovary sits overlying the large maternal vessels. But this was actually a live ectopic pregnancy, so a high risk situation. More commonly, we get these slightly more difficult ones to diagnose. If you compare it to seeing quite an obvious, look at a pregnancy image that we're all used to seeing with a sac with a fetus in. Here, there's what we call a heterogeneous mass. So it's a mass, you can see that it's different, it's round, different to the surrounding tissue. We've measured it one way and then turned and then measured it the other way to measure in 3 planes to get a 3D view. But you can see there's no real sac. It's probably just full of collapsing placental tissue and blood clot as well. They're more subtle because they don't stand out from the surrounding tissue as much, and they can also be confused with ovarian cysts and the corpus luteum, where the patient has ovulated from. So these ones are a little bit tricky, and if this was one I had scanned, I would be more likely to call it a suspected ectopic pregnancy, whereas if you can see this, you're going to say that is a confirmed ectopic pregnancy. So they are sometimes a little bit more subtle. This is a surgical image. So this is a patient that's gone for surgery, gone to have a laparoscope. So they've had an incision at the tummy button. The camera's been put through. They've filled their tummy up with gas, and that's just so that everything, if you imagine, normally your tummy isn't full of air, so all your organs, your bowel, everything is all stuck together. So you blow everything up with carbon dioxide so that you can separate these structures and see more easily. So what we're looking at is, if you imagine we're standing at the head end and we're looking down towards the patient's feet. So you've got the womb here, you've got the ligament supporting the womb. In front of that ligament, this is the fallopian tube, and this is the white bit here is the ovary, and all of that is just sitting on the bowel here. The end of the tube, that's just a very small fimbrial cyst, but you can see this, it's really obvious, this shouldn't be here. This is a dark purple mass, and it's dilating the tube. So the tube should be long and thin and look very much like the rest of this here. You can see that the tube is dilated, it's swollen, it looks purple, and what you're seeing there is the pregnancy tissue within the tube. This isn't ruptured, you can see it's not bleeding, there's no blood anywhere, it's intact, the tube hasn't burst open. So this, I would call this a small unruptured ectopic, as the label would suggest. Now we're going to just come on to look at a ruptured ectopic. So this is a patient I scanned recently. So you can see the womb here up in the corner, and then you've got this structure here which shouldn't be there. You can see it just looks like a bit of a mess. You could imagine that with an eye of faith, imagine that being a collection of blood clots and tissue. Maybe a collapsing sac, this sort of black area here. It's difficult to say because nothing looks particularly obvious, but that could be a collapsing sac within the middle. The bit that's making me suspicious is you can see there's black fluid here, there's black fluid here. Why is it floating? What's all this black area here suggests that this mass is floating in fluid. It's quite large as well. This was about 6 centimetres, so I was suspicious that this was a ruptured tubal ectopic. And when we take it to theatre, you can instantly see the difference. So again, we're looking from exactly the same, we're looking down towards the patient's feet. This is the uterus. This is the normal tube just going off into the distance here, this very, very thin pink structure. This is a very large ectopic. You can see the tube is swollen almost to half the size of the womb. All of this dark here is blood clot. So the tube had ruptured on the outside. You can see where it just couldn't get any bigger because the pregnancy had swelled it so much that the pregnancy is actually burst out. There's then blood clot, and you can see all the blood that is collected lower down underneath the womb as well. So this is a ruptured ectopic that is still bleeding, that needs treatment. And you can see afterwards, I haven't quite cleaned out all the blood yet, but all we've done is just taken off that whole tube. Eagle-eyed surgeons among you will notice that this is the round ligament here, and actually the pregnancy was so close to the womb that we've had to diathermy on the round ligament as well. But you can see they're contrasting the difference. So this whole structure, we've just used surgical techniques to remove, and I'll cover those a bit more in later lectures. And then we would wash everything else out and clean out all that blood. So here, this is an interstitial pregnancy. You'll slightly have to take my word for it, but this is the womb here, just disappearing off. This white line here is the endometrial cavity, and you can see the endometrial cavity just starts to dilate and then just sort of disappears into this jaggedy edge, and this jaggedy edge shouldn't really be here. This is a big mass, so this is some blood, this is clots that have all developed here, and you can see it's, if you imagine, that should be a nice round smooth uterus, and that's all sort of burst out the side. So this is what we found. This is exactly the same patient. This is her scans, this is her surgery. So it's on the other side, it's on the right side this time. So you can see the womb here. we're holding up the womb with suction. This is all the blood that was collected, and this is what you can see here. So when I was talking about something being clear fluid, that clear, pure black that you see on screen, you can see how this is more grey and it looks speckled, and that's how we know it's blood. So that was all the blood we're seeing here. This is the tube coming down to the side of the image, and this purple structure with the clot and the tissue coming out is where it's ruptured. So it's happened where the tube has met the womb, it's joined the womb here, but the pregnancy has actually ruptured more out of the womb than it has out of the tube. The reason they're so dangerous is because there's an enormous blood supply here. It's a really well supplied area, and they just bleed so quickly. So after surgery, we cleaned it all out, took the pregnancy tissue, washed it all out. You can see here, this is the normal tube on the other side, just being held out the way by this instrument. And then on this side, we've had to open up the cavity, scoop out all of the pregnancy tissue, and then repair it with stitches, which was all done through a keyhole technique. And what I find really interesting about this case in particular is that you can still see the normal tube here. And because the point of rupture was removed far from the tube, we didn't actually remove that tube, we just left it. So all the surgery we've done has been through the uterus. You can see it's a slightly heart-shaped womb. I don't know how well that comes across, but it's almost like sort of a figure of 8 or a heart shape, rather than it just being like a round fist shape. And she actually had a slightly bicornuate uterus, which may not have helped. So she had a slightly heart-shaped womb, but she made a good recovery, went on to be absolutely fine. Coming on to just a few more weird and wonderful. So these are things that you won't see commonly, but they can still happen. This is a caesarean scar ectopic. So you're looking at the womb in a sideways view. You've got the cervix here, the womb coming around here. This fluid here is actually the bladder, so that's to help orientate you. This line here represents the caesarean scar. So when you cut through the womb to deliver your baby, you always have a scar there present, and you can see how it's different to the surrounding tissue. This pregnancy has actually embedded itself within that scar, and was only about 3 millimeters away from the interface with the bladder, so where the bladder meets the womb there. Just glancing at it, you sort of think, yeah, oh, that's fine, it's in the womb. And it's only when you very carefully and closely look that you see it's actually separate from the endometrial cavity. Ideally, the pregnancy would be located more fundally, so up here somewhere. And it's only when you really carefully assess and actually measure and look that you realise this is a caesarean scar pregnancy. So she was referred to another hospital and went on to have successful surgery to treat that. So in summary, pregnancy of unknown location is a provisional or a working diagnosis. It's the starting point for you to investigate to identify the likely outcome of this pregnancy. Ectopic pregnancies are unpredictable and they do not follow set rules. So although we like to make these percentage changes and models and flowcharts, not everyone will follow the rules, and it's important to be aware of that. You should therefore use all the information you have available, so place the most importance on the woman's symptoms and signs and what she's telling you that she's feeling. Providing really careful safety net information and advice will reduce the risk. So say to women, we don't know exactly what's going on, so if anything changes, let us know and ask them to come back sooner. So next time we'll go on to cover how do we manage these PULs and ectopic pregnancies, and we'll talk a bit about conservative medical and surgical options. But as you can see, we're 55 minutes now. It's just too much to cram into one session. I hope it's been helpful, and I hope the images have stopped it being all far too wordy. I'd really appreciate your feedback. So from the last session that we did, ectopic was the next thing that came up that most people wanted covered. So I do listen, I will change things, but all your feedback's really enormously helpful to me. So you can either just use your camera phone to scan the QR code or fill in the form, or I can email it to you as well. But it would be super helpful if you could give me a bit of feedback.